So, hello everyone. This time in this video, we are going to talk about another very important topic from which we do expect questions, and these are mostly IPD cases as well as OPD ones. So that is Bullous disorders. So now let's quickly start the topic. So we can classify them into three types at your level. So they can be autoimmune bullous disorders, inherited ones, and mechanobullous. Autoimmune bullous disorders are the ones in which we do have antibody formed against some antigen in the skin, right? So these can further be classified into intraepidermal and subepidermal. We will have a detailed explanation about it. See, intraepidermal are because they are superficial, so they are also known as pemphigus, and they are superficial, so the bulla will be definitely flaccid. Something which is subepidermal, like below the epidermis. So we will have a definitely a tense blister in these cases, and the group is known as pemphigoid group. But remember, dermatitis herpetiformis is a subepidermal disorder, but mostly we see excoriated papule in this case. This is a slightly a different thing, right? Now we have inherited ones. Inherited uh, Bullous disorder, that is they are two, Darier's and Haley disease. And last one is mechanobullous. We do expect one question from this, which is very important topic, epidermolysis bullosa. It is not autoimmune condition, it is mechanobullous condition. And here we do not have antibody. Instead, what do we have? We have a gene defect, right? We have gene defect, genetic condition it is. So it is mechanobullous, right? Mechanical trauma will cause bulla. Now coming to a very important topic, which is basement membrane zone. If you want to build up your basically the autoimmune blister disorders, so you should have a good thorough knowledge of the basement membrane zone. That will help you understand the topic as well. So this is the stratum basale. This is the lowermost layer of the epidermis, and here we are somewhere in between the epidermis and dermis, and this part is known as basement membrane zone, where we have the connection of both these basically epidermis and dermis, right? So this is the epidermis, and here we are the transition. So these are the diagrams. So let us understand what is basement membrane zone. So this is the stratum basale keratinocytes. This is the stratum basale basal layer, and from here we have something which is dermal epidermal junction, right? So this is the basal keratinocyte. Then there will be a layer which will be known as lamina lucida. Then another will be the lamina densa. This is the basement membrane proper. This is also known as basement membrane proper. Then we will have sublamina densa, right? So let us understand what is there in the basal keratinocytes. We have keratin 5 and 14. This is another important question. That keratin 5, 14 is attached to another structure which is hemidesmosome. See, hemidesmosome is there in the stratum basale also, as well as it is there in the lamina lucida also, correct? So there is known as hemidesmosomal intracellular component and transmembranal component. Okay, so this hemidesmosome first see the basically the sequence. So BPAG1 and plectin followed by transmembrane BPAG2 and alpha 6 beta 4 integrin. Let's clear one confusion. This BPAG1 is also known as BP230. BPAG2, this one is also known as important as collagen 17 and BP180. BP180 and collagen 17, it is important because it is there in the bullous pemphigoid ka very important antigen, right? This one, BPAG2 and collagen 17. Now we have anchoring filaments which are there in the lamina lucida. They are mostly made up of laminin 5, but laminin 5 is there in the lamina densa also, right? Collagen 4 as well as laminin 5. Laminin 5 will be there. Apart from them, then we will have anchoring fibrils. It is not filament, it is fibril, which is mostly composed of collagen type 7. Collagen type 7. Again, this diagram, remember the sequence. Keratin 5 and 14, followed by BPAG and plectin, followed by BPAG2 and integrin. In the lamina lucida, lamina densa, which is basement membrane proper, will have laminin 3 to 2, which is laminin 5 only, and type 4 collagen, and followed by sublamina densa, which is type 7 collagen. Type 7 collagen. So we read how many collagen? We read collagen 17, which is BPAG2. We read collagen 4, which is there in the lamina densa, and then we had sublamina densa collagen 7. So This you must remember. So this is the sequence. This is the sequence, right? Apart from this, we are in the stratum basal. Something is there above this also, right? We have keratinocytes, which are hexagonal. Stratum spinosum is there, no? So we have keratinocytes. When we talk about any other pemphigus group, the pathology is here. It is not here. It is here. So if we talk about the connections between the keratinocytes, so then we have something which are desmosomes. Stratum spinosum will have a lot of desmosomes, right? Lot of desmosomes. These keratinocytes are connected by the desmosomes, right? Desmosomes, this is the thing. So this will become epidermal thing. And when we talk about hemidesmosomes, then it becomes subepidermal stuff, right? Basement membrane, subepidermal, and above that, this will be epidermal, pemphigus versus pemphigoid group. Coming to the very important topic, which is pemphigus vulgaris. Now we do understand the pathology is above the lamina, above the basement membrane zone. So it is obviously pemphigus. So what was this? This is desmosome. Which desmosome? This is DSG3, desmoglein 3 and desmoglein 1. Desmoglein 3 obviously is more common in pemphigus. So IgG antibody are formed against this desmoglein, right? Desmoglein 3. So how does this they present? There will be an individual with multiple flaccid bullae, right? They won't be tense bullae. Obviously, flaccid bullae is pemphigus group, and they will give a history of oral erosions. See, oral erosions are seen in pemphigus vulgaris more commonly. Another sign you must know, Nikolsky sign, right? Nikolsky sign will be positive. Histopathology, 100 times this must be asked. Row of tombstone appearance. Why row of tombstone? The hemidesmosomes are intact, but something which was in between is lost. So we have missing keratinocytes here, right? So this is the row of tombstone. These are the tombstone, and this is how it looks. Row of tombstone appearance. The keratinocytes are basically detached from each other, but attached at the basement membrane. But attached at the basement membrane and detached from each other. Here the detachment is gone. Hemidesmosomes are intact. Now DIF, very very important. What is the DIF? This pattern is known as fishnet pattern because the antibodies are against the desmosomes, and all the desmosomes are in the periphery, so they are marked. Center is empty. So fishnet pattern and Zank, very important investigation. If you do a Zank, then we see something which is known as acantholytic cells. So these are the normal keratinocytes. When the adhesions are lost from each other, suppose there was adhesion, and if the adhesion is lost, they become circular, and the nucleus is at the center, right? Nucleus is at the center with a perinuclear halo, and they become circular. That is known as acantholytic cell. They can even give you a picture to identify. What is the treatment? Rituximab, first line treatment almost currently. So you can remember anti-CD20 monoclonal antibody. Another investigations can be ELISA. ELISA against anti-desmoglein 3 and anti-desmoglein 1 antibody. This is also trending. Now we do ELISA also, which is available in the market. Coming to pemphigus foliaceus, obviously this is also a pemphigus group. There has to be a desmosome. So this one is desmoglein 1. Anti-desmoglein 1 antibodies are formed. Another important clue will be seborrheic sites. So what are the seborrheic sites? Do we know the seborrheic sites? Yes, it can be. It can be the face. Face is a seborrheic site. Head and neck basically, right? And the upper chest, upper back, upper chest, upper back, right? Upper back. These are the axilla, face. These are the seborrheic sites, right? And groin also is considered seborrheic site. Now the pemphigus foliaceus, the blisters are so transient. The blisters are very very transient that the patient does not even notice it, right? So mostly the blisters rupture and they form crusted erosions, right? Mucosa, is it involved in pemphigus foliaceus? Very rarely. Mucosa is almost not involved in pemphigus foliaceus. Another variant, we have F, then we have E also. So pemphigus erythematosus is variant of pemphigus foliaceus. So basically there will be malar rash. Basically malar region will have these crusted erosions, and ANA is also positive. This must you can remember. What is the DIF? Again, it will be fishnet pattern, but in the upper layer, same as pemphigus vulgaris. And histopathology will have which split subcorneal. What is subcorneal? So this was the basal layer. We had another layer of the epidermis here, but we have stratum corneum at the topmost, and the split will be just below the stratum corneum, right? Then you can remember paraneoplastic pemphigus. Paraneoplastic pemphigus has plaquins basically. Plaquins will be the problem at your level, although multiple antigens are involved in paraneoplastic, but plaquins. And the most sensitive investigation for this is immunoblotting and immunoprecipitation. And how do you identify? There will be very severe mucosa involvement, very severe, very resistant palm soles involvement will be there. Okay. And pleomorphic. Pleomorphic means variable morphology. There can be blisters, there can be urticaria, there can be bulla, there can be vesicles, anything, right? Urticaria, crusted erosions, multiple, because multiple antigens are involved, right? Not just plaquins, right? But at your level, you remember plaquin. Drug-induced pemphigus, remember PCR, so penicillin, captopril, rifampicin, this you can remember. These are the drugs. Now, coming next to pemphigoid group. This is very important question. Pemphigoid, right? Now we are aware that how pemphigoid group is developing. Something is to be wrong with this, right? BPAG, plectin, BPAG2, integrin, laminin, and collagen 17 and collagen 7. Something has to go wrong with the something below the basement membrane zone. So first disease you must know, bullous pemphigoid. How do you identify? There will be the old age person will be there, 60, 70, although in India 50, 60 people can also have bullous pemphigoid. So they will give history of pruritic urticarial wheals. Okay, they will have pruritus urticarial wheals. Followed by that, they will obviously develop tense blisters, right? This is subepidermal disorder, right? Pemphigoid group, there has to be some tense blister which will not be crusting. They will settle down. They will settle down, right? They will settle down. What is the site? They will all, they will give extremities or trunk will be written, tense blister, itchy, urticarial wheel. Usually head and neck is not involved. So what when you do a biopsy from the edge of the blister, what you will find? Subepidermal blisters for sure. This is a pemphigoid group, and there will be eosinophils. There will be eosinophils. DIF will reveal this pattern. This is what we had basement membrane zone pathology, right? We have IgG and C3 deposits against the BPAG, BPAG2 more than BPAG1. BPAG2 is also known as collagen 17. So these are those antibodies which are deposited linearly. So this is how it presents. And there is another, apart from IgG and C3, we can have IgE antibody, but they are associated with severe disease. These are the tense blister. Can you see how tense these are? And here they have settled down, they are settling down, right? Then we can have two signs here, bulla spread sign. If you apply lateral pressure, then the bulla spreads. And Asbo-Hansen sign, you have to apply perpendicular pressure, so the bulla spreads in all the directions, right? Okay. Now we come to linear IgA disease, linear IgA LIGA, uh, linear autoimmune bullous dermatosis. In adults, it is LAD, linear IgA disease. In children, it is also known as CBDC, chronic bullous disorder of childhood. It is all the same thing. So we have IgA antibodies against this BPAG2, you remember. Actually, it is 97 kilodalton product, cleavage product of BPAG2, but that is also fine. You can have a child, 4 to 5, 6 years of age, right? How will they present? Obviously, there will be tense blisters. There are tense blisters which are arranged peripherally, right? This is known as string of pearl pattern. String of pearl, how tense they are, and they are arranged only at the margin, right? Site will be usually groin, lower abdomen, thigh spate will be there. Again, histopathology, it is subepidermal, right? Subepidermal, but this is not. This is what? This is not eosinophils like bullous pemphigoid. This is a neutrophilic deposit, right? These are neutrophils. These are all chota and neutrophils, right? And also linear deposits on DIF again, but they will be IgA. IgA antibodies are there. This one is for this. The IgA antibodies are there. Okay. IgA antibodies are there, and whenever you see neutrophils, the treatment of choice is Dapsone. Dapsone acts on neutrophil chemotaxis, so that, and DIF reveals linear deposits of IgA, not IgG. Therefore, it is known as LABD, linear uh, CBDC, linear IgA disease, LIGA, right? Okay. Now we have dermatitis herpetiformis. In this, usually a child will be there, and they are also IgA antibody disease. So IgA antibody, anywhere IgA means What will be there? Obviously, neutrophilic infiltrate, right? But different pattern, and the drug becomes dapsone, right? So, but it has HLA predisposition. You can remember HLA-DQ2, HLA-B8, DQ8. So IgA antibody, you should remember, anti-TTG, tissue transglutaminase 3. Remember this 3. This is important, right? So multiple tiny papillovesicles are there. They are so easily ruptured that when they present, we see excoriated papules only, which are present over the extensors. What are extensors? Elbows, knees, buttocks, like lower back. These are extensors. So more than 90%. If you have celiac disease, so if you have this dermatitis herpetiformis, there are more than 90% chances that you have celiac disease also, right? And if celiac is present, only 10% of them develop dermatitis herpetiformis. Now, what will you see in histopathology? You take a biopsy. What will you see? Again, it is subepidermal and it is neutrophilic. Again, subepidermal cleft with neutrophils deposit. But this time, this will be in papillary dermal cleft. Then this pattern becomes, what does this pattern become? Neutrophils are also there, plus यहाँ पे antibodies are also there. This is known as granular pattern. On DIF, we see granular pattern. It is not linear, it is granular pattern. And these are excoriated usually. Papule. Drug of choice becomes Dapsone. Drug of choice, treatment of choice is gluten-free diet, right? For celiac disease also, it is gluten-free diet. But if you want to give some drug for dermatitis herpetiformis, it is Dapsone. You should give neutrophilic infiltrate. You should remember. Now, very important question, epidermolysis bullosa. A child born out of consanguineous marriage develops blisters, right? Blisters over two sides. I mean, they will write either frictional or trauma-prone sites. What are the frictional trauma-prone sites? Limbs, right? Lower limbs, upper limb, hand, feet, all these things are trauma-prone sites. Trauma-prone sites, right? Hands, feet, palms, soles, elbows, groin, wherever friction is present, right? They develop. So it can be of three type, as you all know, simplex, junctional, and dystrophic. The molecule involved, the gene defect is in keratin 514, laminin, collagen, and if you want to also remember, Kindler. Kindler is also a type of EB. Kindler syndrome is also a type of EB, and the gene defect is kindlin or ferment, FR. Okay, this is how it is. So Kindler syndrome is also a type of EB. You need not remember, you need not go deep into it. Although this was my thesis topic, I can teach this for eternity, but yes, we have to stop only since birth, born out of consanguineous marriage, a young, I mean child, blisters over the trauma-prone sites. Okay? This is the gene therapy approved, Verimagine Giperpavec for which EB, RD, EB, if you want to know for INICET or some recent stuff, right? Now, something new which can be asked, usually in INICET, we don't expect this in NEET, but still two methods. We can differentiate this, which disorder I'm not talking about epidermal, I'm talking about subepidermal means pemphigoid group. Pemphigoid group is very, very confusing. So we had to develop something to differentiate. So what we do is it is salt split IIF. In this, there is a split. The tissue is incubated in NaCl like sodium chloride, and then split develops. So where the split develops makes whole of the difference. So it develops in the lamina lucida, right? Lamina lucida. Now you can decide what will show the roof pattern and what will show the floor pattern. So anything above this means plectin, BPAG1, BPAG2. Wherever these antibodies are developed, that will show roof pattern. So for your level, you should remember bullous pemphigoid. For your level, pemphigoid gestationalis, linear IgA disease, everything shows roof pattern, right? Roof pattern. LE you can remember, and anti-epilegrin if you want to, and EBA-LE is important because they are obviously laminin 332 and type 7 collagen in LE and laminin 332 floor. For your level, you remember roof pattern because BP can be a question. New, very new entity, N serration and U serration pattern on on insertion and useration on DIF. See, salt split is IF technique. This is DIF. So insertion and useration. Useration only two. EBNLE, rest is enceration. UEBANSLE. Okay, bullous LE actually. If they give you this image, what is this? Multiple like vertical columns, multiple wells are there, and we have a lot of basically antigens placed, and you take patient's blood and they bind here, the antibodies bind here, and you can know which disease it is. So multiple antigens for pemphigus, bullous pemphigoid, pemphigus vulgaris, pemphigus foliaceus, ठीक है, desmoglein 1, desmoglein 3, BP 180, NC16, BP 230. So all these are there. Monkey esophagus, salt split, desmoglein 3, desmoglein 1, BP 180, BP 230, and we can identify all, many autoimmune bullous condition in one go. So what is this? You just remember the name. This is biochip mosaic. This can be a question. Otherwise, this is it for bullous disorders. And there, this one we can cover in next video, diarrheas and Haley disease. If you have any doubt, you can always send a message. Happy learning. Thank you.